Hello, my name is Jun Chul Park. I am Assistant Professor in Yonsei University College of Medicine in Seoul, Korea. It is my great pleasure to introduce my recent published article in GIE, which is long-term outcomes after non-curative resection of all gastric cancer, the optimal time for additional endoscopic treatment. As you know, ESD is commonly performed for selected patients with negligible risk of lymph node metastasis. Since the reporting of long-term outcomes of ESD, the number of patients undergoing ESD who meet the expand indication of ESD has been increased. Although ESD performed with curative intent, the curative resection of ESD is not always possible. The standard management of non-curative resection is additional gastrectomy with lymph node dissection due to the risk of lymph node metastasis. However, many recent studies have shown that lymph node metastasis found in only 5 to 10% of patients after gastrectomy. I think this standard therapeutic option may be excessive. In addition, determining whether or not additional gastrectomy should be performed is a challenge for a physician because most patients tend to be elderly and have many comorbidities. Therefore, patients who are diagnosed with early gastric cancer with non-curative resection tend to undergo additional endoscopic treatment such as redo ESD or APC, or even some patients were left untreated because of old age or poor general condition. However, there are still no definite standard therapeutic for non-curative resection after ESD right now. Therefore, the ability to determine the risk of recurrence and cancer-related progress for such patients is very, very important. A recent study suggests that patients who undergo additional surgery after non-curative resection have more favorable long-term outcome than patients underwent observation only. But the superior effectiveness of additional endoscopic treatment, except for surgery and follow-up data, have not been established. In addition, when additional endoscopic treatment was performed, especially in patients with positive lateral resection margin, differentiating the resected margin and endoscopic lesion is difficult over time because the primary ESD site being to develop fibrosis during the healing process after first procedure. However, there are not enough data on clinical outcomes after additional endoscopic treatment in relation to time and no constant guideline regarding the optimal time for additional endoscopic treatment. Our study shows that cancer-specific survivor and disease-free survivor were longer in patients who underwent surgery than in those undergoing just endoscopic treatment or observation. However, we should consider alternative treatment options for patients who cannot undergo additional surgery due to old age, many comorbidities, or patient preference. So we analyzed patients with non-curative resection who cannot undergo surgery, and interestingly, no significant difference was found in disease-free survival rate between the endoscopic treatment group and observation group. However, to minimize the possibility of lymph node metastasis, when we evaluate local recurrence for patients with only a positive lateral resection margin, the additional endoscopic treatment group had a higher disease-free survival than the observation group. This demonstrates that additional endoscopic treatment might not reduce total recurrence in patients with a risk of lymph node metastasis, but might reduce local recurrence in those with a low risk of lymph node metastasis, that is, in a subgroup of patients with only a positive lateral resection margin. In other words, this could provide assistance in determining the patient who need additional endoscopic treatment. Regarding redo ESD as an additional endoscopic treatment, redo ESD is expected to be technically very difficult because fibrosis develops within several months, and the presence of submucosal fibrosis is well known as a factor for difficult ESD with longer procedure time and the risk of high risk of piecemeal resection and adverse events such as perforation. Thus, clarifying the optimal time is very important for curative resection. An iatrogenic ESD ulcer usually heals within 2 or 3 months, and it is difficult to identify the exact location of a possible resection margin after ulcer regeneration, because the resected area might have shrunk during the healing process and changing the location of the lesion. Therefore, it is clinically ideal if additional endoscopic treatment is performed only for exact detection of the previous ESD site in redo ESD. However, there's no constant guideline on the optimal time of additional treatment after noncurative resection ESD for early gastric cancer right now. In clinical practice, it is important to assess the exact of tumor precisely before the procedure to reduce the risk of possible lateral resection margin. In analyzing our study population, the patient undergoing endoscopic treatment within 3 months showed a lower rate of local recurrence than those undergoing treatment after 3 months. And the interval on this 3 month basis between primary and additional treatment were shown to be independent predictive factors also. So as far as I know, this study, our data study, is the first to demonstrate that the interval for additional endoscopic treatment is correlate with the risk of local recurrence in patients with only a possible lateral resection margin. So our study could assist the clinician in distinguish which modality should be used for patients who need additional treatment and when the treatment should be performed, especially regarding redo ESD in patients with a lower risk of lymph node metastasis. And we have suggested the optimal time of additional endoscopic treatment in the case of noncurative resection, especially in patients with only a positive lateral resection margin. Thank you for your watching.